Good evening, ladies and gentlemen. I am Dr. J.C. Mohan, and I'm a practicing cardiologist in New Delhi. And this is an IAE-sponsored webinar on prosthetic valve. We have two areas to cover: the assessment of mechanical prosthetic valves. That would be done by Dr. Shanmuga Sundaram, who is a consultant echocardiography and heart failure from Coimbatore, and assessment of bioprosthetic valves, which will be taken care of by Dr. Madhu Shukla, who comes from Jaipur Golden Hospital. You can post your questions below this link, and the questions will be taken. And now, we know, of course, that the prosthetic valve implantation is increasing in this country. Currently, it is believed that a little over 100,000 valve implantations are done per year, and a total cumulative number of individuals who have prosthetic valves in this country probably exceeds 1 million. The evaluation of prosthetic valves is of extreme importance to all of us so that we can detect early dysfunction and take action. In this country, most valves implanted are mechanical valves because our patients are younger, and also the fact that the mechanical valves are a little cheaper and our surgeons have much more experience with mechanical valves compared to bioprosthetic valves. But bioprosthetic valves are also picking up, and hence we need to talk more and more about bioprosthetic valves, which are surgically implanted. Of course, there is going to be an explosion of bioprosthetic valves which are implanted through a transcatheter route in future as the degenerative valvular heart disease increases and the transcatheter prosthetic valve implantation becomes affordable. So we will go to the first talk. This is, as I said, by Dr. Shanmuga Sundaram. It is prosthetic valves, an overview, and mechanical prosthetic valves. Over to you, Dr. Shanmuga Sundaram.
Thank you, sir. Good evening, all of you. Let me thank IAE for giving me an opportunity to be a part of this program. The topic for my presentation is an overview about the prosthetic valves and mechanical prosthetic valves in particular. So I'd like to present the topic in following headings. To begin with, the overview about the prosthetic valves. It was all started in 1954 when a patient with severe aortic regurgitation was implanted with heterotopic implantation of ball and cage process in descending thoracic aorta. We've come a long way since then. We have various types of prosthetic valves, mechanical prosthetic valves to start with, bioprosthetic valves. More commonly, it is xenografts. We do have homografts as well as autografts, and transcatheter prosthetic valves. These are the various mechanical prosthetic valves what we have. To begin with, it was all star Edwards processes, and no more newer implantation of star Edwards process happening nowadays. But we do come across patients who were implanted with star Edwards process earlier. There's a tilting disc process, that's a Chitra valve, and we have bileaflet valves. As far as the bioprosthetic valves are concerned, we have stented bioprosthetic valve as well as stentless ones. Among the stented ones, which have a leaflet intra-annular orientation, supra-annular orientation, and externally mounted leaflets. For all you know, the trifecta valve, which is an externally mounted leaflets, have been withdrawn from the market because of earlier degeneration. And self-expanding as well as balloon expandable transcatheter valves. Coming to the hemodynamics of the valve, as far as the effective orifice area and gradients are concerned, the newer generation valves are better than older generation ones, and mechanical valves are better than stented bioprosthetic valves, and stentless valves are better than stented ones. The supraannular leaflet orientation is better than intraannular. Let it be a transcatheter or let it be a surgically implanted valves. And transcatheter valves have a larger effective orifice area when compared to the surgically implanted ones. As far as the regurgitation is concerned, among the mechanical prosthetic valves, the intravalvular regurgitation is the least with ball and cage processes, and TAVR valve have a higher incidence of mild AR, especially paravalvular AR. So coming to the choice of bioprocesses, age is one of the important determinant, and the practice varies depending upon the centers. As far as the aortic valve is concerned, beyond 60 to 65 years of age, it's primarily bioprosthetic valve, and the discussion starts happening at the age of 50 itself. So 50 to 60 it can either be bioprosthetic or mechanical. Beyond 60, it's primarily bioprosthetic. As for the mitral, more than 65 years, it is primarily bioprosthetic valve. The other factors which are influence the decision making are whether the patient has concomitant indication for anticoagulation or not. For example, atrial fibrillation, whether the patient is desiring for pregnancy or not, what is the life expectancy of the patient, is the patient averse for the risk of bleeding or the averse for risk of re-intervention. All this plays a role in decision making. Coming to the mechanical prosthetic valve per se, coming to the structure of the mechanical prosthetic valves, what is in common is the sewing ring as well as the annulus tension strut, which is common among all three valves. We have a bileaflet valve, which have two major orifices and one minor orifice attached to the annulus tension strut in the hinge region. And as far as the tilting disc valve is concerned, we have one major and one minor orifice with the struts protruding across. And this is the ball and case processes. Coming to the echocardiographic assessment, this is the topic for our discussion. Before starting the echocardiographic evaluation, we need to have clinical information, the date of valve implantation, and what is the size of the processes, what is the type of processes, height, weight, and body surface area, and symptoms related. Is the patient is currently symptomatic or not? What is heart rate and blood pressure? And it is very important for us to review the previous post-operative studies if it is available. One important consideration as far as the assessment of mechanical prosthetic valve is concerned, a lot of ultrasound artifacts like acoustic shadowing as well as reverberation, which is definitely likely to interfere with the assessment of leaflet mobility and the structure of the prosthetic valve per se. Let it be iatic in position or mitral position. Coming to the 2D evaluation, I'll go through the cases which we came across subsequently. So we do have to evaluate the leaflet or occluder mobility, any abnormal densities attached to the various components of the processes, any abnormal densities which is adjacent to the processes, any evidence of prosthetic valve dehiscence, and what's the position of the sewing ring or stent ring. There's a normal bileaflet mechanical processes in mitral position. This is an off-axis view that is basically a short axis where the LV is here, LA is here. You are able to visualize both the leaflets clearly. This is an important view for us to identify the magnitude of the leaflet mobility, which will be easy for us to compare one leaflet with the other leaflet. This is a patient who presented with exertion breathlessness, who underwent bileaflet mechanical prosthetic valve implantation a year back. What you can see is this is the two-chamber view, where one of the leaflet is restricted in its mobility, the other leaflet is totally stuck. So we need to spend time to assess the leaflet mobility clearly so that we'll be able to identify prosthetic valve dysfunction. This is the bileaflet processes in iatic position. As I told you earlier, the ultrasound artifacts are clearly interfering with the assessment of leaflet mobility. So whatever be the view, whether it is parasternal long axis, apical views, or short axis, we usually struggle to identify the leaflet mobility as far as iatic position is concerned. Coming to the stability of the prosthetic valve housing, this is the bileaflet processes in iatic position. You can see both anterior and posterior edges stable, and there is no significant abdominal mobility of the prosthetic valve housing. And if you can see, the anterior part of the sewing ring is clearly attached well, but the posterior part, the mobility is highly abnormal. There is evidence of prosthetic valve dehiscence in this patient. There is another patient who presented with feature suggestive prosthetic valve dysfunction. Here, the posterior part of the sewing ring is stable, and the anterior part is highly mobile. So when compared to the normal, as you can see here. So the stability of the housing is to be assessed and documented. Coming to the assessment of the surrounding structures, as I told you, because of the artifacts, we might at times struggle to visualize the surrounding structures clearly. This is a tilting disc valve which was implanted nearly 10 years back. The patient present with exertion breathlessness. If you can see clearly, the left ventricular aspect of the valve, there is a hyperechoic structure which is attached to it here. Subsequently, the patient underwent a redo mitral replacement. This was confirmed to be a paravalvular abscess. The patient also had significant paravalvular regurgitation. This is a bioprosthetic which is implanted in a iatic position. The patient had a history of fever after a month of implantation. This is echo, which shows the heterogeneously echogenic structure which is noted anterior to the iatic root. Subsequently, he underwent redo surgery where it was confirmed to be a paravalvular abscess. Coming to the abnormal echo densities attached to the prosthetic valve as such. This is a bileaflet valve in mitral position. What you can see is a soft tissue density structure attached to the LV aspect of the valve with limited mobility of the leaflets with prosthetic valve dysfunction stuck valve. Most of the time, it is very difficult to visualize the thrombus. We may not see such a big thrombus attached to the prosthetic valve as such. We need to spend time to identify abnormally abnormal structures which are attached to the leaflets. This is again a bileaflet valve in IATIC position, presented with prosthetic valve dysfunction. What you can see is the soft tissue density structure attached to the IATIC aspect of the leaflet. Patient also had evidence of prosthetic valve dysfunction with high gradients. This is a tilting disc valve in mitral position. The patient presented with fever. On evaluation with transthoracic echo, there is a linear independently mobile structure attached to the left ventricular aspect of the mitral valve. The zoomed view here showing the linear structure, which is clearly. The same patient underwent transesophageal echo, which showed again a larger linear structure with freely significant independent mobility attached to the left atrial aspect of the valve. So what you can see is the left ventricular aspect of the mitral processes is better visualized in transthoracic echo, and the left atrial aspect is better visualized in transesophageal echo. This was a vegetation, and he was subsequently treated with antibiotics. If you can see, there's another patient. This is tilting disc processes in IATIC position. Patient present with features of prosthetic valve dysfunction. If you can see, there is a hyperechoic structure attached to the IATIC aspect of the LV aspect of the leaflet with no significant independent mobility. And if you can see the color jet, there is flow acceleration even before the level of, that is below the level of IATIC leaflet itself. And intraoperatively, this was confirmed to be a PANUS. The patient also had significant prosthetic valve obstruction with high gradients. And this is patient. This is a post redo mitral valve replacement tilting disc valve in mitral position. You can see the position of the leaflet is highly abnormal. The surgeon could only suture at this point because of earlier prosthetic valve dehiscence. He couldn't get a good tissue to suture here. So if you can see, the functional left atrium is quite small. Currently, the patient has severe pulmonary hypertension and severe TR, very symptomatic and awaiting another surgery. There are some other structures which shouldn't be mistaken for a pathological one. There's microbubbles, which are very common in mitral position, either tilting disc or bileaflet processes, shouldn't be mistaken for a pathological structure. So again, suture material is a transesophageal echo, a bileaflet valve. What you can see as a linear structure with no significant independent mobility, which is attached to the LA aspect of the valve. This shouldn't be mistaken for a thrombus or a vegetation. Coming to the color Doppler assessment, we need to assess the antegrade flow. Is there any turbulence? Is there any regurgitation? What is the severity of the regurgitation? What is the location of regurgitation? All this need to be assessed in color Doppler. This is bileaflet processes in mitral position. What you can see, there is a laminar antegrade flow, and which is filling the entire stent frame. There is no significant turbulence. So this is a normally functioning bileaflet processes. In contrast, this is a patient who presented with prosthetic valve dysfunction. If you can see, there is significant antegrade turbulence. If you can see clearly, the antegrade turbulence is more towards the medial orifice. The anterior orifice, there is no significant antegrade flow. And there is a significant antegrade flow here with a significant turbulence. So there is evidence of prosthetic valve obstruction here. This leaflet is totally stuck and there is no significant antegrade flow here. Coming to the regurgitant flow, as far as the mitral processes, intravalvular or paravalvular MR is concerned, because of the ultrasound artifacts, we might find it difficult to visualize the regurgitation. But as far as the IATIC processes, we will be able to see the regurgitation better. The anterior part of the IATIC root is better visualized in transthoracic, and posterior part is better visualized in transesophageal. Apical views will again show the regurgitant jet. I'll go through some of the cases. This is a normal physiological leak which we commonly see. This is bileaflet processes in mitral position. You can see a signature jet which is from the hinge region here, and the valve closure line also has a mild intravalvular leak. The points towards the physiological leak are: one, the regurgitant jet is not of high velocity, and the flow turbulence is happening only at the base of the jet, and it is not a large jet. As far as the mitral tilting disc processes, we might underestimate the severity of the jet as it is shown here. This patient had a severe paravalvular leak by transesophageal echo, but you can see a small jet, which is here. You can see a flow convergence, but the jet is not very impressive here in parasternal long axis as well as in apical view. As far as the aortic process, it's a severe paravalvular aortic regurgitation shown in parasternal long axis, and the much more impressive jet is seen in the apical long axis view. So we might have to resort to transesophageal echo for better assessment. So coming to the spectral Doppler assessment. So before jumping into the analysis of the spectral Doppler tracing, we need to make sure that we have aligned the jet properly. So we'll start with the aortic valve assessment. More commonly, what we assess in apical view, but we do have to look at the jet in right parasternal, supraclavicular, suprasternal, or subcostal views, so that we align the jet, and subsequently we assess the following parameters. What is the contour of the jet? What is the acceleration time, ejection time, AT bar ET, peak velocity, and mean gradient, and some of the flow independent parameters like Doppler velocity index and effective orifice area. We'll come to some of the tracings. This is normal aortic processes. It's normally functioning aortic process. You can see the valve clicks are highly intense. In contrast to the dysfunctional processes, if you can see, the valve clicks are not so intense. Coming to the shape of the tracing, it is a triangular early peaking jet here. In contrast, a mid peaking and a parabolic jet here. This is an obstructed process. Coming to the acceleration time, 80 is less than 80 milliseconds, which is normal here. 80 by 80 again less than 0.32, which is normal. In contrast, here acceleration time is more than 100, and the 80 by 80 is more than 0.37, which is basically obstructed process here. Coming to the velocity and gradient, the peak velocity here is less than 3 meters per second. For all you know, like all the mechanical prosthetic valves are inherently obstructive, so we won't see normal velocities. It is always going to be a higher one. And I think what we need to keep it in mind is the velocity. For the smaller sized valves produce higher velocities. That might even be will look like a pathological one, but we need to keep the prosthetic valve size in mind before interpreting the velocity numbers. I mean, let it be a peak velocity or mean gradient. You need to keep prosthetic valve size in mind. So here it is less than 3 and mean gradient is less than 20, as opposed to more than 4 and mean gradient more than 35. This is clearly a severely stenotic processes. Some of the other determinants for the peak velocity mean gradient are LV systolic function, blood pressure, the stroke volume, and flow state. If it is a low flow state, it can produce lower gradient in spite of prosthetic valve dysfunction. Coming to the Doppler velocity index, there's a ratio of VTA at the level of LVOT divided by VT at the across the valve. As such, we need to be very careful. This is an error-prone measurement where the sample volume should not be very close to the prosthetic valve, where there is slow acceleration, and there'll be spectral broadening, which can overestimate the VTA. And again, as I told you earlier, when we measure the VTA across the prosthetic valve, we need to look at all the possible views so that we align the jet properly. So we have to measure the effective orifice area, which is measured by stroke volume divided by VTA across the processes. Coming to the numbers, Doppler velocity index of more than 0.35 is considered normal, and less than 0.25 is considered severe stenosis. As far as the effective orifice area is concerned, as far as the aortic prosthetic valve, more than 1 square centimeters is considered normal, and less than 0.8 severe stenosis. The indexed parameters are very important for us to assess whether the patient has any patient prosthetic mismatch or not. This is the algorithm which is given in the American Society of Echo guidelines. I'll go through that when I go through the case scenario. Coming to the spectral Doppler parameters for the mitral valve, just like aortic valve, we have to interrogate the jet in various possible views. More commonly, we interrogate in mitral view. Apical view. But some of the obstructed processes will generate a jet which is directed more towards the anterocipitال region, which is better profiled in parasternal long axis. Here, if you can see, the parasternal long axis showed a very high velocity and gradient, where the mean gradient is 29, peak gradient is 41. But if you can see, the apical view didn't really show an impressive jet. So we need to be careful with that. Even short axis view might provide us a good jet. Coming to the interpretation of various parameters, as we did for the aortic valve, we do have various parameters: the pressure half time, what is the shape of the jet, contour of the jet, peak velocity and mean gradient, and some of the flow independent parameters like doppler velocity index and effective orifice area. There's a patient who post mitral replacement baseline echo, where you can see the peak velocity is less than 1.9, and pressure half time here is less than 130, which is considered normal. Here you can see the prosthetic valve clicks are not very well made out, and the peak velocity is very high, which is 3.8, and mean gradient is 27, and pressure half time is 220. So this is clearly obstructed processes. So we have to remember these numbers in mind. The pressure half time less than 130 considered normal, more than 200 considered severe stenosis. And as far as the peak velocity, which is less than 1.9 considered normal, and more than 2.5 considered significant stenosis. Mean gradient less than 5 is acceptable, and more than 10 is considered significantly stenotic. But before inferring these numbers, we need to keep heart rate in mind. Even a normally functioning process with higher heart rate might produce higher velocity and higher gradient. And then occult MR, when we miss a significant MR, that again can produce a significantly higher velocity, higher mean gradient. And more commonly, post-operative patients with anemia and high flow states might have higher gradients, which we need to keep this in mind before interpreting these numbers. Coming to the doppler velocity index, similar to the aortic valve, we do have a DVA for mitral also. But the formula for calculation is different. The VT across the prosthetic valve is in the numerator, and VT at the LVOT is in the denominator. And then effective orifice area formula is similar. And the numbers are here. I don't want to go in detail. It is all available in the guidelines. So the other parameters also has to be looked at, whether the patient has concomitant heart disease, whether the patient has pulmonary hypertension or not, what is LV and RV size, what is hypertrophy or not. So we need to look at all this. So it is always a good habit to generate a fingerprint of the valve, that is baseline echo, ideally recorded at 1 to 3 months after prosthetic valve implantation, where we have a good window, and the patient will not be breathless, and there won't be any anemia or anything. So you can record the 2D parameters, you can record the collar parameters and Doppler parameters, and keep it in the archive, so that when the patient comes back for follow-up, you can compare with the subsequent echoes. I'll go through some of the case studies. To start with, this was a 65-year-old male who has symptomatic severe aortic stenosis, underwent aortic valve replacement with 23 millimeter perimount magna. 2 months post-surgery, was asymptomatic. Blood pressure was normal. His body surface is 1.8 meters square. The LV is not dilated, hypertrophied, normal LV systolic function. The leaflet mobility is not very well visualized in this view. And you can see the color flow. There is some flow acceleration across the valve, but there is no significant turbulence. And if you see the spectral trace, it is a triangular early peaking jet with an acceleration time of less than 100 and AT/ET of less than 0.37. And if you look at the peak velocity, which is more than 3, and mean gradient is 33, it is high. The effective orifice area calculated was 1.29 square centimeters, which is more than 1, which is the recommended cutoff for normal valve. And DVA is, in fact, again, is normal. But the indexed valve areas less than, 0.85. So less than 0.85 is abnormal when the baseline effective orifice area is more than 1. So coming to the algorithm, the prosthetic aortic jet velocity is more than normal, that is more than 3 meters per second. And the acceleration time is again less than 100, and AT/ET is less than 0.37. It is a triangular early peaking jet. The shape is similar to this. The DV is more than 0.30. And the effective orifice area is normal, but the indexed orifice area is less than 0.85. So this diagnoses the patient prosthetic mismatch in this case. The patient also underwent transesophageal echo just to confirm that the prosthetic valve leaflet mobility is normal, and it is normal here. So it is a PPM, and he just need a close follow-up, and does not warrant anything. It falls into moderate patient prosthetic mismatch, which is a very common finding In literature says it is common in 20 to 70% of the patients who undergo aortic valve replacement is likely to have moderate patient prosthetic mismatch. Coming to the next case, this is the post aortic valve replacement with 20 millimeter Medtronic Hull valve prosthesis 20 years back. Now presented with exertion breathlessness for the past 3 months. This BP is normal and body surface area of 1.74. And this is the parasternal long axis view. LV is not dilated, normal systolic function. And the leaflet mobility is not very clearly visualized because of the ultrasound artifacts. And this is the apical view. Again, leaflet mobility is not very clearly seen, the normal systolic function. And this is the spectral trace. The valve clicks are not very well made out. This is a parabolic jet with mid-peaking and very high velocities. If you can see, the acceleration time is more than 100 and AT/ET is more than 0.37 and peak velocity is more than 4 and mean gradient is more than 35 millimeters of mercury. The Doppler velocity index is less than 0.25 and effective orifice area is less than 1 square centimeters. All this indicates a significant prosthetic valve dysfunction, and the indexed effective orifice area is again low. This was the previous echo, which was done 5 years back, where the acceleration time was normal, AT/ET was normal, DVA was normal, effective orifice area again more than 1, and indexed effective orifice area again was normal. So there's definite prosthetic valve dysfunction now. So the peak velocity is more than 3, and the shape of the jet is mid-peaking, and AT is more than 100, and Doppler velocity is index is normal, abnormal, less than 0.25. The patient has either valvular stenosis or subvalvular stenosis. The patient underwent a transesophageal echo here, which shows fairly normal leaflet mobility here. If you can see here, the leaflet comes and goes. It seemed to be normal here. But if you can see the biplane view, you can see a hyperechoic structure which is noted just below the level of valve itself. And the color shows there is significant flow acceleration noted at the level of subvalvular structure, that is probable pannus here. And the patient underwent fluoro, which again showed that the leaflet mobility is normal. The pathology is below the level of leaflet. This is a significant pannus here. So that's what it is. So the patient is being planned for surgery, radiosurgery, because of the symptomatic state. This is a 60-year-old male, post-mitral replacement, Chitra valve done 8 years back. Now with exertion breathlessness class 2 with significant fatigability. He had pansystolic murmur at epics. His hemoglobin was low, it was around 8 grams per deciliter. He also had features suggestive of intravascular hemolysis. This is the image which I showed you earlier. Parasternal long axis, tilting disc process here. There is hyperechoic structure noted here. And there is flow convergence which is noted here, but there is no impressive jet within the left atrium. And again, there is a significant flow convergence noted here in the LV aspect of the valve, but the jet is not very impressive. This is a spectral trace. You can see the peak velocity is high, which is more than 1.9, and mean gradient is also more than 5. And the pressure half time is normal here, which is 72 milliseconds. And the spectral trace for the MR probably suggests a significant MR here. There's a dense trace, systolic trace. So we need to suspect a significant paravalvular leak, though the jet is not very impressive here. We have to look for the flow convergence and the LV aspect, both in parasternal long axis as well as an apical view, which might give us a clue for a significant paravalvular leak. The TE of this patient showed a significant severe paravalvular leak. Also, he also had a mild to moderate intervalvular leak as well. So the TE, sorry. There is evidence of, in fact, vegetation is also noted. I just get this significant intervalvular leak and severe paravalvular leak here, which was not very evident in the transthoracic echo. Blood cultures were negative. He underwent redo MBR after 2 weeks of antibiotic therapy, and the patient is doing well now. So I'll stop the cases here. So multimodality imaging is important. T will come to us for a rescue, more so for the mitral processes, and CT and occasionally MR can obviously help us in identifying the leaflet mobility, paravalvular abscess, and all those structures. To conclude, the transthoracic assessment of aortic valve can be limited for artifacts. CT and fluoro can basically help us in identifying the range of movement if it is not identified by echo. And as far as the Doppler, spectral Doppler is concerned, we have to assess atypical process gradients in all possible views. And elevated gradients, we do have to have a differential diagnosis in mind: high flow state, patient prosthetic mismatch, valvular or subvalvular obstruction, and sometimes pressure recovery. So we need to basically look for one flow dependent as well as one flow independent parameter. That is, I mean, either DVA or EOA. And classification of prosthetic valve leak is concerned, the mild, moderate, severe is similar to that of native valve. Coming to the mitral valve, the structural and hemodynamic evaluation is can be well done by transthoracic and TE. At times, we might have to resort to further imaging like CT or MR. So, like the Doppler parameters which we have to assess, we have discussed, and significant prosthetic valve MR can be missed in transthoracic echo. We need to resort to TE for a better assessment. CT and cardiac MR can be complementary in evaluation of prosthetic valves. Thank you.
Thank you, Dr. Shanmugasundaram, for taking us through the complete and comprehensive evaluation of prosthetic valves, looking at their morphology, morphometry, hemodynamics, and also showing us various kinds of valve abnormalities, prosthetic valve abnormalities, which extend from thrombosis, pannus, dehiscence, infective endocarditis, patient prosthesis mismatch, and hemolysis as well. And you also emphasize that CT is a very good modality along with TEE to evaluate prosthetic valves, although MRI is less often used and its utility is somewhat limited compared to CT. We will have Q&A at the end of the second session. So please place your questions at the end of this video in the link, and we will take the questions as time permits. And now we would move on to the second presentation on assessment of bioprosthetic valves and focusing on early bioprosthetic degeneration by a peculiar mechanism. And Dr. Madhu Shukla, who is head of the Department of Non-Invasive Cardiology in Institute of Heart and Vascular Diseases, Jaipur Golden Hospital, is going to take you through this. Dr. Madhu Shukla. You can use this. You got it? Okay, fine. Then I can stop.
Sir? I am Dr. Madhu Shukla. Just I am Dr. Madhu Shukla. I will be presenting unusual early bioprosthesis dysfunction. Just a minute, there is some technical issue. So, degenerative valvular heart disease is becoming the epidemic of this century. More and more bioprosthetic heart valves will be implanted in the aging population, and bioprosthetic heart valves can be allografts, homografts, or xenografts. The xenografts, which are most commonly implanted bioprosthetic heart valves, they are of two types. One, surgically implanted, which are stented or stentless or sutureless, and others are transcatheter implanted, which can be self-expandable or balloon dilated. Homografts are rarely used in the clinical practice. This is surgically implanted bioprosthesis. It has three parts: a sieving ring, leaflets, and which are porcine or bovine pericardial leaflets, and three stents or posts. Porcine pericardium valves are Epic Supra, Hancock 2, and bovine pericardium valves are Carpentier Edward Perimount and Perimount Magna and Sorin's Soprano valves. If we cut a cross section of this valve at the base, we see three stents or pillars and an annulus. These three stents form a triangle at the base, and this you can see in the video also. Stents and the annulus. Bioprosthetic studs are made of flexible polymer and are cloth covered, as you can see here, and cyclic pressure reversibly bends flexible polymers slightly. This is the cartoon to show. In the systole, the valve opens and the flow occurs through the valve. And in diastole, the valve closes and there is a circumferential compression during the diastole, which causes the compression on the stents, which slightly move inwards. In bioprosthetic valves, we talk about three orifices, but out of these are internal orifice areas and geometric orifice areas and effective orifice areas. But we as a clinician are more important for us is the effective orifice area, because all the gradients are closely related to it. Bioprosthetic valve dysfunction can occur due to wear and tear, fracture, calcification, leaflet tear, stent creep, thrombosis, and endocarditis. Stress and immune reactions are the fundamental factors that limit the longevity of bioprosthetic heart valves. Mechanisms by which these bioprosthetic valves dysfunction can occur, it's a phenocopy of atherosclerosis. The mechanism are mechanical stress, degeneration or calcification, and immune response against xenografts, and deformation of the posts or stents. The structural valve degeneration in aortic valve case, we call it moderate structural valve degeneration if the mean gradient is more than 20 millimeter of mercury, or the increase in the mean gradient is more than 10 millimeter of mercury, or more than 1 grade new or worsening AR is present. For the severe dysfunction to occur, the mean gradient should be more than 40 millimeter of mercury, and increase in the mean gradient should be more than 20 millimeter of mercury, or more than 2 grade new or worsening AR if it appears. These stents have three pores, and there is annulus. These three pores, they work like commissos to support the cusp. As the stent pores are perpendicular to the annular plane, the two triangles are defined by three tips, and the three bottoms of the stent pores should be, these two triangles should be congruent regular triangles. Once inward bending occurs in one or more of the stent ports, the top triangle will shrink. The lower triangle is fixed. The only thing pressure can changes the size of the upper triangle. So when the stent ports they move inward, the top triangle will shrink. As a result, the ratio between the top and the bottom triangle will shrink and restrict the leaflets. This is a study showing that around 15 degree of inward movement or the stent creep, which is called, is it is allowable, it is normal, because it does not affect the flow to so much extent. This is the valve. You can see this is nearly normal vertical pose. This is the T picture. So the posterior leaflet is slightly off axis, but this is within comfortable limit, within 15-degree limit. So this is nearly normal vertical pose with leaflet degeneration. This is another case. You see, this is thoracic and this parasternal view. The anterior leaflet is bent. Anterior stent is bent, and you can see the degenerated leaflets. The inward bending of the stent post without degeneration, which obstructs the outflow tract of bioprosthesis, can cause valve dysfunction, but very few cases of such have been reported. This is another example of the stent creep. Stent creep is the inward movement of the inward displacement of the stent post, causing obstruction to the flow. There are few cases which I am going to present. This is first case, 72 years old male, presented with dyspnea class 2B for 2 years, had CABG, AVR and carotid and arterectomy on April 17, 2013, and AVR was done with 21 epic St. Jude aortic bioprosthesis. He was not in failure. BP and was maintained. He had intermittent LVV and old inferior wall MI was there. The normative data which was supplied by the manufacturer showed that the mean pressure gradient for a patient with epic supra is 15.5 millimeter of mercury with the annulus diameter of less than 22 millimeter. So routine echo was performed on January 29, 2014, 9 months after the AVR in the other hospital, and they found the gradient 68 by 43 millimeter of mercury. Patient came for the second opinion for us, and we did the echo and we found the gradient 57 by 30 millimeter of mercury, and we called this patient for follow-up later on. And after 2 years, 2016, February, we found the gradient was 74/42 millimeter of mercury. And that comes the area around 0.7 centimeter square. And this is the parasternal view. You can see there is inward bending of the anterior post in this patient. And the flow is restricted through this valve. And this is the T picture. You can see the two posts which we are able to see. Both of them are inward bent, and there is mild AR, and the inward bending of the stents have made the way for the flow tunnel-like. You can see more pictures here. And this is the 3D picture of the same to show from the LV side, the aperture is large, but the dark hole you are seeing inside is the actual from where at the apex the blood is passing. So at the apex the valve is narrow, and at the base it is it is larger. So, but the effective orifice area will be according to the upper aperture. So conclusion is, this is the prosthetic valve stenosis with area 0.7 centimeter square with mean gradient of 30 to 40 millimeter mercury at different times. This is a stent creep phenomena, and leaflets are normal. This was the patient which we reported also case study in Journal of Indian Academy of Echocardiology in 2020. And this is more if somebody wants to see it. And this is the second case, 60 years male who had AVR with epic supra 25 in 2030 and presented with shortness of breath after 5 years. And he was symptomatic. BP and heart rate were stable, but he had definite ejection systolic murmur at base and LV type of apex. ECG showed LVH with strain. This is the ECG of this male. And this is the parasternal long axis view of this patient. You can clearly see the stent creep. Both stent posts are inward inclined, and you can see more. You can see the stent creep, and in the other side view, you can compare it with the normal, where the stents are vertical and they are not bending inwards, and they are normal. But in the stent creep, these stents move inwards at the apex, causing obstruction to the working of the normal leaflets. Even leaflets may be abnormal, but they obstruct the movement of the normal leaflets also, and the flow is obstructed. These are the more views. You can see the stent creep. So this is inward moving stent creep. Diameter is reduced, and the upper basal diameter is 20 mm, the upper diameter is 11 mm. So it has become, the aperture has become a tunnel-like, which is narrow at the apex and more larger at the base. This is the short axis. You can see the leaflets are normal, and 3 stent posts you can see here. You can see here more picture. And again, you can see the narrow aperture. The vena contracta of the flow going inside is only 8 mm. You can see here. And this is pseudo-normal mitral inflow pattern. And the gradient here is, mean gradient is 21 millimeter of mercury with aortic wall area of 1.1 centimeter square. For a size of 25, this gradient is high. And this is the 3D picture showing again the stent creep. You can see here, whenever you measuring the stents size of these triangles, you should keep the marker at the center to avoid the blooming effect. Here, when we calculated the stent creep ratio, that is the ratio of the upper triangle and the basal triangle, came out to be 0.65, which is very significant. In fact, basically, basal triangle and the upper triangle, if the stents are normally placed vertical, then the ratio should be 1. If the ratio goes below 1, then stent creeping can be predicted. But if it is more than 20%, then it becomes more significant. This is the case which I have recorded today only. This is a male who has undergone AVR with Merrill aortic flow mirror pericardial valve on last month only, on 8th. And you can see the stent creep here and AR also. So stent creep causing bioprosthetic dysfunction is an uncommon mode of structural deterioration of bioprosthetic heart valves defined by permanent inward deflection of the stent pores. This can occur because of the valve oversizing and leads into valve stenosis. Clinically significant stent creep is considered to be a rare type of bioprosthetic degeneration. It is reported in some cases to be only cause of prosthetic dysfunction even in the modern bioprosthesis. Now, how to measure the stent creep, which I have already told you have to measure the lower triangle and the upper triangle, and you have to make the ratio of it. Ideally, it should be 1. If it is less than 1, it is important, and it is more important if it is less than 0.8, more than 20%. If it is reduced area, then it is important. This is another way to show. You see the lower triangle and upper triangle, and more than 20% reduction is clinically very significant. This is another study which is showing stent creep ratio goes negatively with the transaortic gradients. So the common mechanism for stent creep are circumferential strut compression is common in narrowed aortic roots, and circumferential strut compression can occur in oversized valves too. This cyclic change may rarely result in permanent deformity. Other possible etiologies are small aortic root implanted with a relatively large bioprosthesis, traction of the stents due to overlying cloth tissue ingrown, incompetence to diastolic flow, and mechanical fatigue of the stent material. So stent creep, the gradients are high across the wall due to leaflet restriction, and this itself can cause promotion of the degeneration of bioprosthetic leaflets due to constant friction. This is the Heron's formula, which can be used to calculate the area and stent creep ratio. This is a study, successful treatment of failing bioprosthesis by stent creep. You can put valve-in-valve transcatheter aortic valve implantation. This is a series of 3 cases. And the summary is, it is important to distinguish the leaf dysfunction and the stent creep. Transcatheter aortic valve-in-valve implantation has been used to treat this failure due to stent creep, and it is the only way which is the best one to treat such stent creep. Thank you.
Thank you, Dr. Madhu, for talking a peculiar mechanism of aortic bioprosthetic degeneration, which does occur in mitral prosthesis degeneration also. And we now actually are open for Q&A. Let me read the questions. One of the questions, and I think Dr. Shanmugha Sundaram can take it, is how to assess diastolic dysfunction in prosthetic mitral valve replacement patients.
Yeah, I mean, so the conventional parameters like mitral inflow E velocity, E bar A ratio, because angular velocities can again cannot be measured. So E bar E prime again, it's not possible. Left atrial enlargement most of the time will be there because of the earlier mitral valve dysfunction itself. So majority of these conventional parameters may not be of any use. Only thing is, if the prosthetic valve function is normal and gradients are well within normal range, and the patient has significant pulmonary hypertension, probably that might suggest which can be attributed for diastolic dysfunction. Otherwise, like conventional parameters are, I don't think will be of any use. And majority of the time, the diastolic dysfunction as such may not be very relevant in the prosthetic valve replacement. So we most of the time are bothered about diastolic function and prosthetic valve function as such.
I would agree with you. I don't think there is any fun of assessing diastolic dysfunction, diastolic function in prosthetic mitral valve replacement. And I think, I personally think that there isn't any condition where you really require it. There is another question, and we need to find out whether is there any cutoff for aortic? Same. Yeah. So the point is any cutoff of aortic prosthetic heart valve mean gradient to indicate high gradient.
Conventionally, the peak velocity more than 3 and mean gradient more than 20 is considered as high. But before interpreting these numbers, we need to keep the prosthetic valve size in mind. The smaller the size of the valve, for example, or 17 or 19 size valve, is likely to produce a higher gradient even if it is normally functioning. So where the peak velocity can go up to 4 meter per second and the mean gradient can go up to 30. At the same time, higher size valves like 27, 30 are likely to produce lesser gradient. So it's better to keep the normal numbers which are given in American Society of Echocardiography as well as ESCBA guidelines in mind before interpreting these numbers. So velocities are interpreted or just like, they shouldn't be just interpreted like a numbers. It should be interpreted in congruent with the prosthetic valve size and what is the flow state, what is the systemic blood pressure, what is the systolic function of the ventricle, is it a low flow, low gradient? So we need to keep all these parameters in mind and finally interpret the numbers.
Yes, I think as far as the cutoff for aortic prosthetic valve mean gradients are concerned, largely the fact remains that a peak velocity above 3 meters should be suspicious. And above 4 meters, definitely you should have a very high index suspicion. We know that pressure recovery phenomenon through the narrow orifice of the bileaflet valves can cause very high gradients in a normally functioning bioprosthesis. So that is why morphology is important, morphometry is important, and you need to actually find out if everything is all right, patient doesn't fit with patient prosthesis mismatch, there is no restriction of the leaflets are working all right, there is nothing below the leaf valve and there is nothing above the valve, then of course the pressure recovery phenomenon is a strong possibility. The issue actually would be individuals who have left ventricular dysfunction. In them, actually, you would have to rely much more on morphology of the prosthetic valve rather than gradients. And I would say that no particular gradient can be taken as normal or abnormal with left ventricular dysfunction. However, in bioprosthetic valves, you don't commonly see pressure recovery of that magnitude. It does occur. We know it does occur, but it's not of that much magnitude. It probably accounts for a small amount of higher gradients. And that is why the European Society of Cardiovascular Imaging has given those numbers that anything above 20 millimeter mean gradient, you should consider moderate structural valve degeneration, and above 40 severe structural valve degeneration. Of course, this is much more important if there is an increase in 10 millimeter gradient over serial follow-up, but then you are also ruling out initially set patient prosthesis mismatch. There is another question, Dr. Shanmugha Sundaram, we all can take it, and that is how to reliably distinguish between thrombus and pannus.
So if the thrombus is really large, it used to be a soft tissue density structure attached to the either atrial side or ventricular side, which can be visualized either in transthoracic or transesophageal. But many of the time, such a large visible thrombus is not a very common finding. Most of the time, the patient will have an obstructed processes, clinical prosthetic valve dysfunction. Patient might be in pulmonary edema, where we may not be able to really see the visible thrombus. At that time, we will struggle whether it is thrombus, pannus, what is the reason for prosthetic valve dysfunction, where TE also may not really yield. As far as the pannus is concerned, it is more hyperechoic when compared to thrombus. It is not really a soft tissue density. If it is visible, well and good. Again, the visibility of pannus also may not be so easy with ultrasound artifacts when we assess prosthetic valves. So when we are really in doubt, we can resort to a CT. CT scan, the hypoattenuated leaflet thickness and restricted leaflet mobility will be in favor of thrombus. Pannus will be more of hyperechogenic. So, like, I mean, transthoracic, at times transesophageal will show us. If not, we can think about CT depending upon the clinical scenario. But I mean, there might be combination of both. Pre-existing thrombus on the top of it, I mean, pre-existing pannus on the top of it, thrombus can form. So there will be combination of both, where we may not be able to clearly point out to one particular pathology where it is just only thrombus or pannus.
Yes, I agree. I think we need to remember a few things. First is, how has the patient presented? If presentation is acute, then chances are that we are dealing with the thrombus or thrombus superimposed upon a pre-existing pannus. If the history is insidious, more chances are that we are dealing with a pannus more often, not necessarily always. Number two, of course, you also have to keep in mind the INR. If the INR is subnormal, chances are you may be dealing with a thrombus. But then remember, these are just pointers. They are not absolute things. The third thing you rightly said is that if you can see a globular round ovoid mass on the either side of the leaflets, which actually also shows some mobility, then chances are you're dealing with thrombus. Pannus is always immobile. Pannus is more often circumferential. So if you do a good transesophageal echo, you would find structures which are impinging upon the internal diameter in a variable fashion, but largely the same structure is circumferential. More important, if you see nodularity on transesophageal echo, nodularity is always, nodular means multiple nodule-like appearance on the sewing ring, that usually is suggestive of a pannus. You rightly said that if you are not able to make out, I think CT is a very good way. If Hounsfield unit of this abnormal mass is less than 50, it is thrombus. And if it is more than 100, more like 130, 140, it is a pannus, because fibrous tissue has a higher Hounsfield unit, and thrombus usually have 20, 30, 40 Hounsfield unit. I think that should probably solve the problem. But one important thing is, more often we should be using CT. We are using less often CT. We should use it more often. And we also have to say that cine fluoroscopy cannot differentiate between thrombus and pannus. So don't say that we have done a cine fluorography and we are able to tell what is what actually. One question which is actually, I think, important, how to prevent patient prosthesis mismatch in AVR?
Yeah, I mean, at the time of implantation, the size of the annulus and surgeon itself, like, I mean, they usually will have a chart, the predicted effective orifice area and the likelihood of PPM for a given size. For example, if they are likely to choose a 21 size valve, what is the likelihood of PPM the surgeons are aware of? So, like, are they, like, I mean, if the likelihood of severe patient prosthetic mismatch, they can try to increase the size of the annulus. So, like, I mean, this is all the risk versus benefit. Obviously, the root enlargement procedures carries its own risk. So we need to weigh the risk and benefit. If it is possible, root enlargement has to be done if the initial assessment is predictive of a severe patient prosthetic mismatch. If it is moderate, most of the time surgeons tend to ignore that and just go ahead with the size. If it is a severe PPM is a predicted one, they try to do a root enlargement and do it. So it is risk versus benefit. And what we need to be aware is, like, the effective orifice area for a given bioprosthetic valve, stented bioprosthetic valves are a bit smaller than the mechanical prosthetic valves. So we can choose appropriately. And TAVR valves has a better effective orifice area when compared to SAVR valves. So we can choose TAVR instead of SAVR if that is a clinical scenario. So we can, surgeon can avoid, and we can choose the right size, the right type of the process, which can avoid.
I would agree with you. And of course, the technique of implantation, whether you're doing supraannular or intraannular, will also actually try to avoid patient prosthesis mismatch if you put a supraannular valve. But you rightly said that the TAVR is reducing the chances of PPM much more because you are definitely getting 50% bigger area for the same individual. One of the other things which you can think of, if the person is obese, losing weight actually will actually help in preventing patient prosthesis mismatch. We don't talk of that often, but it would be quite helpful. Design of the valve also makes a difference. Besides the supraannular position, we also have to agree that ball and cage actually are high profile valves. They have higher gradients and lower area. Bileaflets are much better. Even amongst bileaflets, some people are trying to differentiate based on the area you are achieving. And I think beyond the St. Jude's, we have moved beyond the St. Jude's, and I think the newer ones, Onyx probably gives a slightly better valve area. So that those would be all what we have to comment on patient prosthesis mismatch. But having said it, it still is an issue, but you can try to prevent it. Aortic root enlargement, we talk a lot, but surgeons are not very fond of it. They know the issues which can occur because of this. The more debridement you do of a calcific valve, chances of complete heart block increase, chances of perforation increase, annual rupture increase, dehiscence increase, and also to some extent actually endocarditis later on increases. And also fistula between aorta and left atrium, between aorta and right atrium. So it is a double-edged sword. When you say, I will decalcify the valve as much as possible, you can land up into significant amount of difficulties.
Yes.
There is another question which says, will severe AR affect calculation of mean gradient in severe mitral stenosis? Very interesting question.
Yeah.
So I will take that question and you
please.
make a comment on that. So one of the things which we have realized over a period of time is that gradients, whether peak gradient or mean gradient, across a valve, let us say mitral valve, is also dependent upon, is actually basically gradients are dependent on transmitral gradient. So what is the left atrial pressure and what is the left ventricular diastolic pressure? The difference between the two will decide what would be the gradients. If the left ventricle is highly compliant, normally compliant, then mean gradient would be what it has been reported in the literature. Aortic regurgitation, aortic stenosis, both actually increase the left ventricular diastolic pressure. And especially severe AR increases the left ventricle and diastolic pressure, causing a rapid actually deceleration. And so the peak gradients are high. But the end result also is there is some effect on mean gradient also. So remember, we are talking about filling in early diastole. If that also contributes to calculation of mean gradient. If you really talk of the end diastolic gradient, I would still say the end diastolic gradient would actually be decreased with severe AR. But if you are talking of mean gradient, it actually could be increased because in early part of diastole, you are actually producing higher gradients because of what you call as reduced net atrioventricular compliance. Now, reduced net atrioventricular compliance takes in consideration the fact that the left atrium compliance and ventricular compliance in severe aortic regurgitation slowly, because this is both pressure load and volume load, left ventricular compliance decreases. And that is why left ventricle mean diastolic pressure high and end diastolic pressure high. This will result in higher mean gradients. But you also have to keep in mind that there will be a bigger disparity between peak gradient and mean diastolic gradient whenever there is severe AR. That also needs to be kept in mind.
Yes.
So I don't know whether nowadays you calculate net left atrioventricular compliance, because there are two formula. One is flash cam formula actually, and another is Jim Thomas gave this formula back in 1988.
one formula uses pressure half time, and the other formula uses deceleration slope, not deceleration time, deceleration slope. And both the formula give you net left atrioventricular compliance. Normal left atrioventricular compliance is 4 to 8 millimeter per centimeter square. Now, I'm sorry, 4 to 8 centimeters cube per millimeter of mercury. That is so the milliliter comes first, 4 to 8 milliliter per millimeter of mercury. That is the normal. Less than 4 is subnormal left atrial compliance, which would give you higher gradients. And more than 8 means highly compliant, net atrial compliant lower, and that will give you for same area lower pressure half time and lower deceleration slope, which means shorter deceleration slope and shorter pressure half time.
Okay. For all this combined value lesions, 2D mitral varia is much more easier and more reliable parameter than looking at the gradients.
Yes, I think the issue of mean gradient which is being raised, we need to remember the mean gradient one part of the story. Calculation of valve area would be probably by planimetry would be much more accurate in such situation in a severe AR case. But in addition, you might say that you would like to use continuity equation, and continuity equation will also most likely give you right kind of valve area in a patient with severe AR. Although we also have to agree that studies have clearly shown presence of MR and AR may affect estimation of valve area by continuity equation. And in severe AR, if you want to use continuity equation, you should take RVOT stroke volume. RVOT stroke volume divided by VTI of the mitral valve would give you correct continuity equation mitral valve area. So in severe AR, trick is not to use LVOT stroke volume, but RVOT stroke volume. Well, there seems to be no more questions, and I think we can wrap it up. We had a great discussion on prosthetic valves, and I hope the audience enjoyed it. We tried to cover as much as possible. And I have to say, Dr. Shanmuga Sundaram actually presented absolutely fantastic images of all kind of complications which can occur with prosthetic valve. And Dr. Madhu Shukla showed you a completely different type of prosthetic valve dysfunction. And I'm sure even Dr. Shanmuga Sundaram did not talk of that because it is such an uncommon thing, although you would be surprised it is reported since 1988. The so-called stent creep phenomena, permanent inward bending of the post is reported for a long time. And usually it occurs along with the valve degeneration. So people actually don't try to calculate it separately. But Dr. Madhu Shukla showed you two cases where 9 months after AVR, you had stent creep and very high gradients. Another was 1 month after AVR. Now, this 1 month after AVR with a flow Miro valve, we have very little experience of this valve. We don't know, but it also has the 3 posts, same way as the other valves have it. But we were surprised that we had so much of stent deformity occurring within a month of implanting a Merrill bioprosthetic aortic valve. So we would like to learn more from people who have experience of this, and we will also encourage you to look for stent creep in future, so that this of course, whether you have a stent creep or you have valve degeneration, the treatment would continue to the same. But stent creep can produce much earlier valve dysfunction than usual degeneration, which occurs in about 30% people nowadays at 10 years. and gradually the degeneration getting less and less. Most of these valves are being treated with glutaraldehyde, and now gene knockout valves are also being created, which would actually cause much less degeneration. Thank you very much for all of you, and a great thanks to Dr. Shanmuga Sundaram and Dr. Madhu Shukla, and to Indian Academy of Echocardiography for giving us this opportunity to discuss this whole gamut of prosthetic valves, both mitral and aortic. We know we did not discuss tricuspid valve and pulmonary valve, which are relatively uncommon prosthetic valve replacements. And if time permits, some other day we will take care of that thing. So good night and have a wonderful week ahead. Thank you.